Hi, everyone. Welcome to our webinar. Today's topic is infectious diseases update, COVID, flu, and monkeypox. We've missed seeing you in the past month, and we're glad you could join us. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare and your moderator for today's session. A number of you have probably joined us for past webinars and know our routine, but I just want to go over a few quick announcements before we get started. The session is being recorded. You will be on mute for the entirety of the session. You will be submitting your questions via the Q&A function. You can do that anytime during the webinar. The webinar will last for 1 hour. We'll be uploading the webinar recording on our YouTube channel within the next day or two. And so you'll be able to find it there as well. I'm going to turn it over now to Dr. Johnson because she has a lot of material to cover. First, I'd like to tell you a little bit more about her. Sarah Johnson, MD, MPH, is an Associate Medical Director at WorkCare. She's based in Los Angeles and works closely with some of our clients in the entertainment industry. She's also involved in the development of medical protocols, policies, and consultations for a number of our other clients in different types of industries. Prior to obtaining her medical doctorate degree and her master's in public health, she was a public school teacher, so she has an interesting background. I'm sure you'll enjoy hearing from her, and now I'm going to turn it over to her. Thanks again for joining us.
Thank you, Karen. So today I'm going to be talking about updates on infectious diseases. We'll be covering COVID, monkeypox, and the flu. So first we'll start with COVID. At this point, everyone is very familiar with COVID, probably feeling fatigued about hearing about it, but there are some important new updates that employers should be aware of. So we're going to discuss what the current numbers are, any variants of interest that you should be aware of, the new boosters that are available, the most recent CDC guidelines on both isolation and quarantine, as well as what the best practices are for managing COVID in your workplace right now. So the good news is COVID cases are on the decline overall nationally. Cases are down about 30% over the past 2 weeks. Hospitalizations are down about 10%, and deaths are also down about 10%. Cases are probably somewhat underestimated because a lot of testing is being done with at-home testing currently, and those tests usually are not reported to public health departments, but even still, cases do seem to be declining, so that's good news. In terms of variants, so variants are, what's been causing a lot of the problems with COVID. What you need to know about variants is that, first of all viruses have the capability to mutate over time. As viruses replicate or create new copies of themselves, there's a chance that there can be a change or an error in the code, which results in a different end virus when compared to the original copy. Different viruses do mutate at different rates. So something like a flu virus can mutate fairly rapidly, which is why you see a different flu vaccine each season to try to address those genetic changes. Any mutated virus is called a variant. Sometimes the errors are very small and there's no real major changes between the parent copy and how the end copy behaves. But if there are enough mutations or mutations that cause a change in how the virus behaves, we can call it a strain. Sometimes you will hear the words variant and strain used interchangeably. An example of how this happens is with Omicron. There are about 34 mutations in the spike protein alone, which resulted in a different behavior. In this case, it became more contagious and it was easier to infect the cells. The main thing that you need to know about variants is that the more infections, the more opportunities there are for new variants to develop, because each time the virus has a chance to enter a host cell and replicate itself, there's chances for new mutations and therefore new variants. You can think of it, if you were to copy a 500-page manuscript by hand, and you were to do that over and over again, the chance of you making some kind of error is definitely there. In terms of the current variants, right now, Omicron remains the dominant variant in the United States. As of this time, the WHO hasn't reported any new variants of concern or variants of interest, but that can change in the coming months. So it's just something that we have to watch closely. So boosters, at this point, you probably all know that at the end of August, the CDC approved Pfizer and Moderna's new bivalent booster. Bivalent just means that the formula is a mix of the original vaccine, which covered the original version of the virus, but it also has a formula that targets BA4 and BA5, which are Omicron subvariants, which are very contagious and what caused a lot of the surges in the recent months. The Moderna vaccine booster is approved for adults 18 years and older. Pfizer is approved for people 12 years and older. In terms of how you should advise employees, the advice is still the same. If someone hasn't been vaccinated, we do recommend that they start with their primary series. Right now, that's either Moderna, Pfizer. There's also a new protein-based vaccine called Novavax. Some employees who are concerned about the newer mRNA technology might be more comfortable with Novavax because it is a protein-based vaccine, which is a technology that's been around for a long time. It's the same technology used for hepatitis B vaccine and also for HPV vaccine. So those are a few options that are out there. Johnson & Johnson is still available for primary series, but generally it's not recommended unless a patient requests it specifically, or there are components of the other viruses or other vaccines that make it contraindicated for them. So main message is just you want to stay up to date on your vaccinations and your boosters. So ideal timing for boosters. So the minimum window is 2 months after your most recent dose. I get a lot of questions about after someone has been infected, when can they get a booster? The answer is you can really get a booster once your infection has resolved. But for some people, it might make sense to wait a little longer. As much as 4 to 6 months, you can get a better immune response to the booster. Also, in certain populations like young men, there is a small risk of having post-vaccine heart problems like myocarditis, which is inflammation of the heart. So in those individuals, it's recommended that they wait a little bit longer, up to 3 months after they recover from their infection to get that booster. Most experts at this time are saying that people will probably only require 1 COVID booster per year. But again, we'll see how things go in this upcoming season. So a common question is, if I get a COVID vaccination, will it interfere with COVID testing results? The answer is no. The vaccine doesn't give you COVID. It doesn't introduce the virus into your system. The diagnostic tests, like a PCR test or a rapid antigen test, look for actual virus in your system. So getting a COVID vaccination or a booster will not cause you to test positive on a COVID test. So this isn't something that employees need to be concerned about. So the most recent CDC guidelines, you're probably generally aware of this. The isolation period was shortened from 10 days to a minimum of 5 days. It's important to know that there's 2 different groups. So asymptomatic people should isolate for a minimum of 5 days from their positive test. However, if they do develop symptoms, the timing should be from the onset of symptoms. So if someone tests positive on a Sunday, but doesn't develop symptoms until Tuesday, you would time the 5 days from Tuesday. So that's just something to be aware of. If an employee is to return to work prior to the end of a 10-day isolation, you want to make sure that their symptoms are getting better. Not all of their symptoms might be gone before they go back to work, and that's okay, but you want to make sure symptoms are getting better overall. You also want to make sure your employees are fever-free for at least 24 hours, and that's without needing fever-reducing medications. So things like Tylenol or ibuprofen. These employees also need to wear a well-fitting mask through day 10 because there is a chance that they could still be contagious in that window from day 5 to day 10. In terms of types of masks, I wouldn't recommend anything less than a surgical mask, which provides droplet precautions. but COVID is aerosolized, so an N95 or a KN95 is a better choice than a surgical mask here. And I wouldn't recommend cloth masks for this purpose. So CDC does not have a blanket guideline to test these people before they come back to work, but it is a best practice to do so. We do recommend that at day 5 or the day before they're due to return to work that you do a rapid antigen test. The reason being, if someone is still testing positive at day 5, there's a good chance they're still contagious and capable of passing the virus to other employees. And so it's best to keep that person at home either until they complete the full 10 days or until they are testing negative. It's also recommended that you consult your occupational health professional or your state guidelines, because some states like California do actually require testing before coming back to work if the person is not completing a full 10 days. A note on the type of testing, if you see here, I specified antigen testing. That is because PCR testing is very sensitive and it can detect even inactive virus circulating in the system for up to 90 days after that initial infection. So antigen is just a better choice for early return to work. Next up is quarantine, which addresses people who are close contacts but have not become ill yet. So this is a big change from what we were doing a year ago, but quarantine is no longer recommended for asymptomatic close contacts, regardless of their vaccination status. One exception to this that I recommend is for people who have high-risk contacts, like household exposures. With a variant like Omicron that's extremely contagious, if someone is in the same household as a positive case, the chances of them becoming infected is very high. The good thing is the incubation period is fairly short. So if you keep them home for at least 2 to 3 days, that's the time frame in which they're most likely to become sick. And so I recommend, if you have a household exposure, like a spouse, a roommate, a child, keep the person home for at least a few days and then test them before you bring them back to work. Similar to people who are positive, they do need to wear a well-fitting mask through day 10 and continue to self-monitor for symptoms. If they develop symptoms, they should be sent home and referred for COVID testing. These people, according to the CDC, should be tested at least 5 full days after last exposure. So you want to set that up for your employees as well. So COVID-19 rebound, you may or may not have heard about this, but President Biden experienced it over the summer. The CDC issued an alert in May about Paxlovid, which is an antiviral treatment indicated for people who either have severe illness or are at risk for severe illness, like people who are immunocompromised. It does lower risk of hospitalization and death, but it can cause rebound COVID, meaning a person recovers from their COVID infection and then several days later goes on to develop new symptoms and or test positive. It's important to note that this can also occur without using Paxlovid, as it can just be a normal part of the disease. We don't know a whole lot about rebound, but the recommendation is that these individuals repeat that 5-day isolation to reduce the risk of spread. The good thing is most COVID rebound cases tend to be mild, and it doesn't indicate that you need to repeat treatment with Paxlovid. Another issue with COVID that we've all heard about is long COVID. So these are symptoms that linger. They can last weeks or months after someone has been infected. About 20% of people in this country report having long COVID symptoms. So that's a pretty significant share. There's different kinds of symptoms they can experience, things like fatigue, respiratory issues like problems breathing or a cough. But these things can really impact your workers' ability to do their job. So some of the long COVID impacts, these people are almost 4 times more likely to miss work because of their long COVID symptoms. There's a cost associated with it. It's estimated about $9,500 within the first 6 months from things like doctor's visits, hospital stays, and prescription medications. So you really want to make sure your workers are staying up to date on their vaccinations and boosters and taking the appropriate precautions to keep from getting sick. So some general recommendations for managing COVID in your workplace. Pretty simple, but you just want to continue to encourage employees to stay home if they're feeling sick and to report their symptoms to the appropriate work contact so they can be evaluated. I think this is a big culture issue. It does seem to be shifting somewhat, but you want to make sure you move away from the culture of people just pushing through. And even if they're having minor symptoms, they want to stay home and report that until they've been cleared. You also want to encourage your employees to get tested if they develop COVID-like symptoms. At-home tests are fine if you're having symptoms or an exposure. They're actually pretty good tests, but the FDA does recommend that if someone has a negative antigen test, whether it's done at home or in a medical clinic, they should repeat that test either like 1 or 2 days later. That's because antigen testing is somewhat less sensitive than PCR testing, and doing serial or repeat testing can improve that sensitivity. If you have someone who's a high-risk exposure, like someone with a household contact, and they test negative initially, consider either repeating that test or just keeping that employee out for 5 days and having them test before they come back to work. Also, make sure that if there's someone who you suspect may have COVID and is coming back to work after day 5, you want to keep them masked through day 10. Next up is influenza. So we haven't heard a whole lot about the flu lately. Influenza is mostly transmitted through large respiratory droplets. So over the past several years, where you have people in quarantine, people masking and social distancing, makes it a little bit harder for the flu to spread. But now that a lot of those COVID precautions have, been taken down, we might see something different happening this upcoming flu season. So this is an important thing to keep yourself aware of. So we're going to talk about signs and symptoms of flu, what the new flu shots look like, and how to manage influenza in your workplace. For the average person, most people recover from the flu at home with supportive measures. So things like getting plenty of rest, drinking fluids, taking over-the-counter medications as needed. But in certain populations, like people with underlying conditions, the immunocompromised, or pregnant people, they can have more serious complications, including hospitalization and death. The flu can also cause disruptions to your workflow when workers are not feeling well to return to work. So these are, important things to consider. So COVID versus flu symptoms. So there's a lot of overlap, things like fevers, chills, headaches, cough, body aches, but there are some key distinctions. With COVID, you're more likely to see brain fog, which your employees might describe as, I just feel out of it, I'm having a really hard time focusing. If you hear that symptom, you should be thinking more towards COVID-19. Also, if they report a new loss of taste or smell, or a change in those senses, like someone might describe having a metallic taste in their mouth, or things just don't taste as strong, that should also make you more concerned for COVID-19. While both COVID and the flu can cause gastrointestinal problems like nausea, vomiting, or diarrhea, you are more likely to see those symptoms in children with the flu, so that's another thing to keep in mind. So incubation and infectious periods for COVID versus the flu. So with Omicron, the incubation period tends to seem a little bit shorter, like 2 to 3 days, but technically you can become infected 14 days after your exposure, your last exposure. Whereas the flu, it's a little bit shorter of a period, usually 1 to 4 days after exposure is when people will start to exhibit symptoms. In terms of infectious period for COVID, people tend to be contagious 2 to 3 days before their symptoms start, and it can last about 10 days. Once you get beyond 10 days, most people are not contagious anymore. With the flu, your contagious period can begin 1 day before your symptoms start and can last about 7 days. With both COVID and the flu, people tend to be more contagious early on in the infection period. So flu shots. So we do have some new things with flu shots this season. Important to know who it's recommended for. It's recommended for everyone 6 months of age and older. So most of your employees will be eligible based on age. But there are 3 special flu vaccines this season that are recommended for adults who are 65 and older. These special vaccines either have ingredients added to improve the immune response, or they're given at a higher dose. So if you have older employees, they should consult with a healthcare provider to see which vaccine is recommended for them. In terms of timing, you want to get your flu shot before the start of the flu season. Right now is actually an ideal time to do it. So September, October. If you don't get vaccinated by October, not all is lost. You can still get vaccinated and have some level of protection. Also important to notice, if you do still get the flu, being vaccinated can actually result in a milder illness. For people who were hospitalized due to the flu, a study from 2021 showed that there was a 30% reduction in the chance of them either being admitted to the ICU or dying. So even if you still get the flu, even if worst case scenario, you end up in the hospital, it still does provide some level of protection. So a common question is it okay to get a COVID vaccine and flu vaccine at the same time? The answer is yes, that's okay to do. So you can schedule both of your booster and your flu shot at the same time. You might want to get them in different arms just because of, soreness, but studies show there's no change in the immune response, no change in side effects when you get a COVID vaccine and a flu shot at the same time. One exception to this is the monkeypox vaccine, which we'll talk about a little bit later. But if someone is exposed to monkeypox, they don't need to delay getting vaccinated because they were recently vaccinated with a COVID booster or vaccine. However, if they are electing to get, or they've elected to get a monkeypox vaccine, they might want to wait at least a month before they get a COVID vaccine, just because in young people, there is a risk of myocarditis. So that's just something to consider. Another question, some people wonder if getting the flu vaccine gives you the flu, or if I got the flu vaccine, why did I still get sick? So there's a few different reasons that can happen. So number one is that the flu vaccine does not give you the flu. That's important to understand. But when you get a vaccine, it causes your body to mount an immune response, and that's what we want the vaccine to do. So that can be something as simple as soreness, swelling, pain at the injection site, or it could be more systemic symptoms like headaches, feeling tired and achy. So if you have those symptoms soon after vaccine administration, it might just be your body giving an expected response to the vaccine. The second reason this can happen is vaccines in general, like the flu vaccine, take about 2 weeks to become fully protective. So if you were exposed to the flu vaccine, if you were exposed to the flu, either just shortly before you got the vaccine or within a couple weeks after, you might still be susceptible and get the flu that way. And then the third way could be the flu vaccine has to match the circulating flu viruses. So I had mentioned earlier, the flu virus does change pretty rapidly. So there might not be a complete match between the vaccine that's been developed and the flu viruses that are circulating. But even so, if you do get infected with the flu, the vaccine does help give you a milder case of illness. So it's still worth getting vaccinated. So managing influenza in the workplace, pretty similar to COVID. So you want to make sure eligible employees get their flu vaccine. You can do things like hosting a flu clinic on site. That's pretty common in medical workplaces. You can also give your employees time off to go and get vaccinated, and you can encourage them, hey, you can get your flu vaccine and your COVID vaccine or booster at the same time, so they can kill 2 birds with 1 stone. Again, any employee who's sick should be encouraged to stay home and report their symptoms. You want to recommend COVID testing an employee with flu-like or COVID-like symptoms just so you can rule that out. And if flu is suspected, in general, you want people to stay home for at least 4 to 5 days so they're out of work during that most contagious period. You also want to make sure that they're feeling better before they come back. No fever for at least 24 hours without fever reducers. So next up is monkeypox. The good news is cases are actually downtrending overall in the United States, but I'll talk to you about what monkeypox is, give a little background. We'll talk about monkeypox versus COVID so you can distinguish the two, how it's transmitted, what the course of illness looks like, how we diagnose and treat it, what vaccines are available, and some basic guidelines for managing monkeypox should you see it in your workplace. So in August, the White House declared monkeypox a public health emergency. It is part of the orthopox virus, and it's a DNA virus related to smallpox, as opposed to COVID, which is an RNA virus. As of September 12th, there are about 22,000 confirmed cases in the US. We think there are 2 monkeypox related deaths so far, one in California, one in Texas. Both occurred in severely immunocompromised people. So the majority of people who get it seem to do fairly well, but most cases continue to occur among men. About 99% of cases are among men in the United States, and mostly among men who have sex with men. The median age for infection is somewhere in the mid-30s. So how is monkeypox transmitted? So there are a variety of ways, but by and large, the most common way it's transmitted is through close physical or intimate contact. So things like kissing or sexual activity. New England Journal of Medicine did a case studies recently where they looked at about 500 or 600 cases globally, and about 95% of those cases transmission was estimated to be caused by close physical intimate contact. Monkeypox can also be transmitted by large respiratory droplets, but again, this is less likely. It can also be transmitted by fomites, which is basically touching a contaminated surface, so something like bedding, and getting infected that way. But because most of the transmission is via intimate contact, probably won't become a huge issue in your average workplace. So signs and symptoms to look for, things like fever and rash. Almost all cases of monkeypox will have fever and rash. They can also have swollen lymph nodes, like in the neck, feeling lethargic, having headaches, body aches. As you can see, there is some overlap with both COVID and flu. COVID can also have a rash. The lesions in monkeypox are pretty distinct and they go through phases. So they start out as a flat discoloration, and then they can turn into something that looks more like a pimple, firm and raised. Sometimes they can have sort of a dimple in the center. These lesions usually show up about 1 to 3 days after systemic symptoms like fever. They can really appear anywhere on the body, but you tend to see them in anogenital regions. And the course of the rash is after it develops, it will eventually dry up, scab off, and form new skin over where that lesion was. It can also lead to scarring. So the incubation period for monkeypox can be pretty long, so anywhere from 3 to 17 days, kind of similar to COVID, but on average, it's about a week. So that's the time from when you get exposed to when you develop symptoms. The infection itself can last quite long, so 2 to 4 weeks, and that's because people are considered contagious until the lesions are fully healed. So they have to scab over, fall off, and form new skin before someone is not considered contagious anymore. So this is important to know because as you're planning your policies in the workplace, these people might be out for an extended period of time. So you either want to have something in place for disability or for remote work if that's available. So monkeypox versus COVID-19. So this is a pretty busy slide, but in terms of how widespread it is, there's a big difference. Monkeypox, like I mentioned, we have about 22,000 cases versus COVID since it began. There's been about 95 million cases in the United States, so much larger difference in how widespread they are. In terms of transmission, again, monkeypox is mostly with close, intimate contact, whereas COVID-19 can be spread through tiny droplets in the air, so much easier to catch COVID-19 than monkeypox. Also, signs and symptoms, there are a lot of symptoms that overlap, but that characteristic monkeypox rash is really not something you see as much with COVID, although COVID can have a rash as well. So how do we diagnose monkeypox? It's important to note that your employee who might report to you, hey, I have this rash, I'm concerned. You want to get that person to a healthcare professional to get checked out, because there's lots of different things that can cause rashes. Different viruses like chicken pox, the measles can cause rashes. Sexually transmitted infections like syphilis can cause rashes. Also things like scabies, COVID can cause a rash. So you want someone who knows what they're looking for to get that person checked out. If after doing a full history and physical, monkeypox is suspected, that person would be referred for testing. PCR testing is a diagnostic test of choice, similar to what we do with COVID. Different specimens can be used to test for monkeypox, so things like the nasopharynx, like we use with COVID, or you can also swab lesions, which is actually the preferred site to test for monkeypox. For those who test positive for monkeypox, most cases are self-resolving with supportive care and people who are healthy, but there are antiviral medications available in the United States. Tecovirimat, or TPOXX, is an antiviral that's approved for smallpox, but it's currently available under emergency access to treat monkeypox. So this is typically reserved for people who have a severe infection or who are at risk for a severe infection. Like, so for example, someone who is immunocompromised or a young child who is under the age of 8. So vaccination options, there are 2 vaccines in the US that can be used for monkeypox. One is called Jynneos. It is in limited supply, so that's something to keep in mind for that vaccine. The other one is ACAM 2000, has more availability, but it also has more side effects and contraindications. So some of the side effects it has are myocarditis, which is inflammation of the heart, pericarditis, and also has contraindications in people who are pregnant, immunocompromised, and some people with skin conditions. So isolation for these individuals, they need to isolate at home for the duration of their illness, which again could last anywhere from 2 to 4 weeks. If they are unable to isolate, they should stay home at least while they have any fever or respiratory symptoms, so like coughing. If their fever and respiratory symptoms are no longer present, technically they can exit isolation, but they do need to wear a well-fitting mask. Again, we recommend N95 or KN95 in this instance. And they also need to keep the lesions covered at all times, because coming into contact with the lesions is one way you can get infected. So lesions should be covered with things like either gloves, clothing, bandages. This is only in a critical instance. Really, if you have someone who has been confirmed with monkeypox, the best mode of action is to just keep them home for the full duration of illness. And again, you want to make sure lesions have scabbed over, healed, new skin is formed before you bring these people back to work. So during the contagious period, you want to make sure you don't share items that have either been worn or handled by the affected person. So things like bedding, PPE, eating utensils, just make sure you don't share those things. You want to disinfect any surfaces or items that have come into contact with the lesions. Avoid close physical contact. This is pretty easy to do in the workplace, but if the person lives with an employee, so the employee is a close contact, you want to counsel them to avoid close physical contact with their family member or roommate until that person has recovered from their infections. People with an infection should also avoid crowds, congregate settings, so like a crowded meeting room is a bad idea. And you also want to encourage frequent hand hygiene, so washing your hands with soap and water for at least 20 seconds or using an alcohol-based hand sanitizer. A note on cleaning and disinfecting. So the virus can survive on surfaces for an extended period of time. One study found that the virus survived for up to 15 days on undisturbed surfaces. This is particularly true if it's in an area that's cool, dark, and with low humidity. More porous materials like linen or bedding have a higher risk of harboring the virus. But the good news is that typical cleaning like hot water and detergent are usually sufficient to kill the virus on linens. Also on hard surfaces, really any EPA registered disinfectant is going to be sufficient to kill the monkeypox virus on surfaces. You do want to make sure that you're following the instructions for using those cleaners. So some cleaners need to have the surface wet for a certain amount of time before it's considered disinfected. You might have to repeat the process. You also want to make sure that any staff you have that's doing cleaning is using the appropriate PPE. So that probably includes gloves. It might include a mask. If someone is doing housekeeping, you don't want to have them shake out linens, anything that could cause stuff to become airborne. So managing exposure. So as a consultant, I've already had this happen where an employer has come to me because one of their employees had been exposed to monkeypox. And so the general recommendation is that these people are not required to quarantine if they're not having any symptoms. So that is good news for the workplace. They can continue to do routine activities like going to work or school. Because again, those are not places where you're typically going to have that close, intimate contact required for transmission. During the 21 days after they've been exposed, you do want to instruct them to self-monitor for symptoms. So they should be looking for things like fever, swollen lymph nodes, rash, headache. Any of those should be reported, and they should stay home if they develop symptoms. Any cases that are suspected should be referred to occupational health or to a licensed healthcare provider for evaluation and testing if indicated. Some do's and don'ts for monkeypox. So again, you just want to make sure employees are educated about signs and symptoms to look for and the things they can do to keep themselves safe. Similar to COVID and the flu, make sure people who are sick know that the work culture is that you stay home when you're sick and you notify the appropriate work contact. While most workplaces will not be overwhelmed by monkeypox, or at least that's the prediction, it is good to have a written policy in place just in case. You will probably have at least one employee who either suspects they have monkeypox or has been exposed. So it's just a good idea to have something in place in case that happens. You want to make sure you have a plan in place for managing significant absences. Again, monkeypox infection can last anywhere from 2 to 4 weeks, so that's quite a long time to be out of work compared to the flu or to COVID. You want to make sure your management is well trained on recognizing infectious disease and what to do if they encounter it. And then you can just continue with the routine environmental cleaning. No need to do anything really special, just regular cleaning should be sufficient. One thing you don't want to do is panic. Because of how monkeypox is transmitted, we don't expect it to be a huge issue in the average workplace. You just want to make sure you have a good plan in place. You also don't want to stigmatize people who are infected or exposed. If people feel like there's a stigma associated, they're less likely to disclose if they're feeling ill or if they've been exposed, and that could present a risk in your workplace. Also, you want to avoid, anything that could appear like discrimination. Finally, if you have an employee with suspected monkeypox who's supposed to travel for work, you want to keep that person out of travel until monkeypox has been ruled out. There are some countries right now that are doing monkeypox screening on arrival, and so you want to avoid a situation where your employee gets stranded abroad. All right, does anyone have any questions?
Thank you, Dr. Johnson. And we do have some questions. A lot of them are related to the first part of your presentation on COVID. So we'll start with those and then work down through the list. And just as a reminder to everyone, please submit your questions through the Q&A function, and we should have plenty of time to answer all your questions today. So the first question regarding COVID is, are they using the old formulas to make new vaccines, or is it all new formulas?
So that's a great question. I actually don't know the answer to that if they're reusing the old formula, but the ingredients, at least for the old formula and the bivalent, the ingredients for the old formula would be used in the bivalent vaccine, but I don't know if they're recycling the same stores. So that's a great question.
Okay, well, we can probably answer that in follow-up for the person answering that question and anyone else on the webinar today. If you're using the WorkCare COVID-19 risk stratification and return to work process, does WorkCare follow the new guidelines? In other words, no longer isolation for asymptomatic close contact, regardless of vaccination status.
Yes, so we are able to tailor things to a client's wishes. So different clients will have different requirements. Like I have some clients who are subject to union requirements, so they might still have to quarantine. But in general, we do follow the CDC guidelines, and we also, try to make sure that we are also following the state requirements. So for our clients in California, they might have different requirements for isolation. But in general, for most states, quarantine is not required for asymptomatic close contact. So that's what you would see in the portal as well.
Okay, thank you. For COVID, if someone tests positive after 5 days, do they need or should they have a negative test before coming back to work? Is keeping them out for 10 days without testing an acceptable option?
Yes, so that's a great question. You have two things you can do, and this does also in some part depend on your state. In some states, if a person tests positive after 5 days, it's recommended that they sit out for the full 10 days and then they can return to work at that point. If you want to do that, that's a very good option because beyond 10 days, almost no one is contagious at that point unless they are still not feeling well or they have an active fever. So those would be two things that would indicate to you that this person isn't ready to return to work. But if they're feeling better, no fever for 24 hours and 10 days has passed, they can return on day 11 without needing a test. Alternatively, if you want to bring them back sooner, they test positive on day 5, you could try to test them again on day 7. If that's negative, put a mask on them and you can bring them back to work and they just need to mask through day 10.
Okay, great. Thank you.
Mhm.
Next question, would having been hospitalized for COVID pneumonia be considered a reason to take Paxlovid?
It could be. It really depends on that person's underlying conditions and if they have any contraindications for Paxlovid. Additionally, there are some IV medications that are available for people with severe illness. So it really just depends on the physician and the team who's taking care of them, what medications they might be offered.
Great. Okay, next question. It starts with a comment. Another recent CDC guideline change was that the onus will no longer be on businesses to require unvaccinated people exposed to the virus to quarantine at home. Do we know if or when this change will be adopted by local regulators, such as the California Department of Public Health? And I presume this question would apply in other states as well.
Yes, that unfortunately, I don't know the answer to. The CDC tends to move quicker on regulatory changes, and then the states do tend to lag, especially states that are more medically conservative, like California. It could take weeks or even months for them to catch up to CDC changes.
Yeah, I haven't heard anything about state activity in response to that guideline, the CDC
Yeah,
guideline.
I haven't either.
Yeah, so I'll look into that along with the other question that we want to elaborate on. So the next question is about monkeypox. It's actually kind of two-parter. Can a person be asymptomatic with monkeypox? And if they are asymptomatic, can they still spread the virus?
That is a great question. I would say it's probably possible because I know not everyone with monkeypox will have a rash or have a fever, but the overwhelming majority of cases do have those things. So I haven't yet heard of an asymptomatic case. I would say even if you're asymptomatic, if that were to happen, yes, you are still capable of transmitting the virus because if it's replicating in your system and it's detectable on a PCR test, then I would say the risk for being contagious still exists. But I don't really have information on that for sure.
Okay. Do you happen to know which countries are currently screening for monkeypox upon arrival?
I do not, but I can find that out and report back. I believe it's a handful of countries.
Okay, would that be predominantly countries where it's endemic, do you think, or not? Oh, maybe not.
Yeah, I'm not sure. That's hard to say.
Okay, we'll look into that as well. Great questions today. You're stumping the experts. Next question. Is it true that if you had the smallpox vaccine, you may have immunity?
This I would have to look into because Jinios and ACAM 2000 are, designed and they're smallpox and monkeypox are the same virus family. I don't know what level of protection you would have. And with most vaccines, protection does wane over time. So depending on when you had that vaccine, it would be hard to say how much protection you still have. But that's something I can look into. That's a great question.
Okay. Should we be doing flu testing and COVID testing for anyone who shows up at work with symptoms?
If you have the capability to do it, certainly wouldn't hurt, because then it'll give you a better idea of what's going on with that employee, and you can tailor the recommendations.
How do you test for flu symptoms?
Usually it's just a swab, so similar to a COVID test.
Oh, okay.
Yeah.
Yeah, I don't customarily hear about people testing for the flu, or they may have it mixed up with just the common cold.
Yeah, sometimes you'll see, not often, but you'll see COVID and flu testing done together at a lab. And so you'll get a report that has both COVID results and flu results. So it can be done.
Okay. Okay, this question is, I'll just read it. It's not really a question, it's a comment. Discuss the pustules or blisters some people are getting as a result of COVID infection. You were talking about pustules and blisters, or the outbreak with monkeypox. I don't know that much about the COVID rash.
Yeah, so it's less common, but it's possible. And really with any virus, you can get a rash. I haven't really seen pustules, but I suppose it could be possible. The monkeypox is the one really where you more tend to see the blisters and the lesions that look kind of like raised, firm pimples. Some of the COVID rashes I've seen were more like flat, and they can really appear anywhere on the body. So like on the trunk, on the arms, on the legs, it just depends.
What causes a COVID rash or a rash of any type after you've had a sickness? Is it your body? I've always kind of felt like it's your body eliminating the infection through your skin as a as a means of exit, but I don't really know what the epidemiology is.
Yeah, so it could just be a reaction from your immune system. When you get an infection like a virus, you have an inflammatory response, so you can get a rash as a result of that.
Okay. When do you think the CDC and the World Health Organization will change the pandemic status of COVID now that it seems to be more of an endemic than a pandemic?
That is a good question. It's something I can't really answer. I don't know what their plans are, but I think if cases continue to decline and we don't see, a surge in the fall or in the winter, then maybe at that point, they'll consider changing the status.
Okay, are you recommending that employees who have a close contact exposure to monkeypox virus wear a mask when they return to work for the days when there's a possibility of respiratory transmission of the virus? The CDC originally recommended to wear a mask in June 2022, but then removed that recommendation.
Yeah, so that's a good question. I would say it depends on the type of exposure. If they just had a one-time brief exposure, then masking probably isn't necessary. But if someone has an ongoing exposure, like a household contact, I would probably recommend to wear at least a surgical mask in that situation.
And what recommendations do you give to employees who are still testing positive after 10 days on a rapid antigen test and have minimal symptoms? Are they still infectious? Do they continue to test until they're negative?
Yeah, so that's a great question. We don't know a lot about what a positive test after day 10 means, but if you want to take the more conservative route, the recommendation would be to keep them out until they're testing negative, because if they're testing positive, there is a chance that there's still, active virus there. Another option, though, is you can send them back to work and put a mask on them until they're feeling better. But beyond 10 days, most people are not contagious at that point. So in general, we don't even recommend testing after 10 days. But if someone should happen to and they test positive, probably best idea is just to keep them home until they're testing negative.
Okay, back to COVID. This is a good one I hadn't thought of. Will the only COVID vaccines available from now on be booster shots? Will people ever have to get a full 2-dose set of Moderna and Pfizer again, like we did when they first developed the vaccines?
So that depends. If you have never had a primary series, it is still recommended that you complete the initial primary series. If you have had that, then from now on, all of the boosters are that bivalent booster that has both the original formula and the BA4, BA5 targeted formula. So you most likely won't have to repeat a primary series. You would just get a booster dose each year just to improve your immune response.
Another COVID question. Do you have any statistics on COVID-19 cases which have been reported to OSHA as work-related?
That is a great question. I don't have any numbers off the top of my head, but that's something we could look up.
That's been a little complicated because the CDC changed the way they were tracking cases and reverted it to hospitalizations. And then there's kind of other sicknesses intermixed with that.
Mhm.
And then when a sickness is reported to OSHA as work-related, it may not be determined to be COVID if it's pneumonia or something else. So
Right.
we can see what we can find for you. Never simple.
Yeah.
What are the key strategies for managing or tri-infections? For example, a combo of COVID, flu, and/or monkeypox.
Yeah. So if you were to be so unfortunate as to get all three, you would go with, in terms of like isolation period, the illness that has the longest one. So you'd want to keep a person out like that for 2 to 4 weeks, basically make sure lesions have completely healed over and form new skin. I don't know if being co-infected would worsen the severity of illness, but that's something that would be managed by your employees' healthcare provider in terms of determining, do they need something like Paxlovid or an IV medication for COVID, or if they need TPOX for monkeypox. But those are all conversations they would have with their personal doctors.
Sure would not be fun to have all three at once.
No.
I suppose it's feasible.
Yeah, I mean, anything is, you can certainly have COVID and flu at the same time. And so I don't see why you couldn't have monkeypox as
Yeah,
well.
I remember that happening earlier in the pandemic.
Yeah.
Considering it is now said that regular face masks provide little to no protection against COVID, when will masks no longer be recommended in areas of high transmission? I ask this because our company continues to require masks for everyone when area counts are high. Employees are beyond weary of being required to wear masks for 12 plus hours.
Yeah, so there is definitely a lot of mask fatigue. I don't know if I would go so far as to say that the masks don't provide any protection, because different types of masks have different levels of protection. So something like a cloth mask might not be terribly helpful if there's aerosolized virus, where something like a professionally fitted N95 that does protect against aerosolized transmission. So if you're using a higher grade medical mask, that does help with preventing infections, not just COVID, but also things like the flu. In terms of when masking will go away completely, again, that's really hard to say, but I think, anytime there's a surge, employers are likely to recommend masking in those situations. But if case counts are low, things are downtrending overall, then masks become less critical to wear.
Okay, this next one's a really helpful comment. I'll go ahead and read the comment and then you can respond. On the matter of stigma and population in relation to monkeypox, how can mentioning the fact that monkeypox is seen more in populations of people who are men and have sex with other men not create stigma? In the workplace, that statistic is unnecessary, as it is a social susceptibility cofactor, not biological or physical. It seems that this mentions only with the purpose of putting minds at ease that it is nothing to worry about, although in the same breath, we can also state that there are several different ways to contract this virus.
Yeah, so that's a great question. I think that's something that's been discussed quite a bit. I would agree that in the workplace, you don't necessarily have to, mention that to employees. But as far as a public health standpoint goes, it is important to discuss, because we need to know which groups of people are most at risk for getting infected. So in a situation like monkeypox, where you have limited stores of the Jynneos vaccine, you want to make sure you're prioritizing those stores for people who are most likely to become infected. So yes, not necessarily something that needs to be a big issue in the workplace, but in the public health arena, it is important to be aware of, the population that is most impacted. You could say it's similar to COVID-19, where people who were older were more susceptible to severe infection. And so when things like vaccines are in limited supply in the beginning, you want to prioritize people who are most at risk.
Okay, thank you for that comment. Do you have any idea when Health Canada may approve the Pfizer bivalent vaccine?
No, I'm not familiar with what Canada's plan is for that.
We'll have to look that up. So I think what we'll do is take all the questions we want to elaborate on and send the answers to everyone who's enrolled in the webinar, so everyone can get all the answers. We have a couple more questions. In your opinion, what do you think is the next most likely contagious disease to emerge?
I mean, that's a very hard question to answer. I don't think that's something that can really be predicted. It's more just an issue of, making sure we have the proper systems in place to address the next thing that comes up. I mean, we might not see another pandemic in our lifetime. It just really depends. But I think experiencing COVID and experiencing monkeypox does give us at least some idea of the things you need to do to mobilize quickly and get things under control, because COVID definitely caught us off guard.
In your experience working with different client companies, how successful do you think that most employers are in having a pandemic plan and policy in place, or just a infectious disease management plan in general?
I think now, that we're a couple years into COVID, most employers that I work with do have a good plan in place. If it's something you feel is a weak spot in your workplace, I would highly recommend consulting an occupational health professional. They can look at the unique aspects of your workplace and make recommendations for you. But most of the clients I work with, because they're already, consulting us, they have a good plan in place.
Hey, another question just snuck in. Do we need to be concerned about polio?
I haven't heard a lot of it, being something that workplaces need to be concerned about right now, but, things can change, but I haven't heard anything of that being, a major concern right now.
Okay, not a question, but I disagree with the commenter, the relevance for sexual transmission for monkeypox. Sexual transmission as a primary vector does allow employers to assess priority risk based on risk. Oh, let me read that again. Sexual transmission as a primary vector does allow employers to assess priority based on risk. Aerosol transmission versus sexual transmission does allow employers to gauge risk related to workplace activities. There is a significant difference. So it's a comment, not a question, just for discussion's sake.
Okay.
And one last question, and then I think we're out of time. Given that the last couple of flu seasons were relatively mild, largely due to the practice of other precautions during the height of COVID, what do you expect for the upcoming flu season? I know that's also hard to predict, but it seems like there might be some complacency around flu season this year that might be a little misguided.
Yeah, so I think in general, people are, either wary or tired of hearing about vaccinations and boosters. And so that could easily transfer over to flu vaccination, although flu vaccines have been around for a long time. So hopefully there's not as much, safety concerns that people had with the mRNA COVID vaccines. But we can look to Australia as a potential model. Their flu season occurs before ours in the calendar year, and they did see a surge in flu cases this most recent flu season. So it is something that we might see in the fall and winter. So people really need to be prepared for that. And again, right now is the ideal time to get your flu vaccine, so September and October. So just make sure you're encouraging employees to get that done.
Which reminds me of one other question I had, and that's regarding, for older people, advised to get pneumonia shot, advised to get shingles shot, flu shot, COVID shot. And I know you talked about mixing different vaccinations and that it's okay to get two at the same time. But what if you're kind of bombarded with all these different ones? Should you pace it out? What's the best course of action?
Yeah, so that really depends on what vaccines you're scheduled to get and, what age you are. Similar to like, infants, they might get multiple vaccines on one day. So that's something I would recommend talking to your personal doctor about to see what they recommend for your situation based on what your risks are and what your underlying conditions are.
Okay, well, we're out of time. I want to thank everyone so much for joining us today. And thank you so much, Dr. Johnson, for your expertise. We really appreciate your time and attention to this very important topic. And we'll look forward to seeing you all again when we have our next webinar. We'll be announcing it shortly.
Thank you.
Everybody stay safe and well. Thanks again.